Hi everyone, welcome to the video for module 5.1.2. We're still in the introduction to bone tissues. I just split this one up because it had quite a bit of information in it. So if you look here, again, you'll see the learning objectives for this module. Please use these to help with the module quiz as well as the exam once we get to that portion. So continuing with the introduction to osseous tissue, we're going to go with fractures here. And a fracture is a crack or a break in the bone, and usually these are classified on the basis of, one, whether the bone penetrates the skin, and we can consider those either simple, where the bone breaks cleanly but does not penetrate the skin, or compound, or also known as opened, and that's when the broken ends of the bones protrude through this tissue in the skin. We can also classify it on the orientation of the break, and those can either be transverse, where the break occurs perpendicular to the long axis of a bone, or linear, where it breaks parallel to the long axis of the bone. And then thirdly, we can compare them based on the position of the bone ends after the fracture. So they can either be non-displaced, so the bone ends retain their position, or they can be displaced, where the bone ends are out of normal alignment. There are a few types of fractures that we're going to talk about here. These are the ones that I'm going to hold you responsible for in lecture, but there are several others that we're not going to cover here. So among the few that we're going to cover, we already talked about open and closed. We talked about transverse as well. Spiral is going to be just a twisting motion that pulls segments of the bone apart. You have a comminuted fracture, which can have several breaks in one bone, and the bone fragments are going to be in many pieces. You can have impact fractures in which one fragment is driven into another caused by compression. That's also known as a compression fracture. You can have green stick fractures in which one side of the bone is broken or the bone breaks incompletely. And you can have oblique fractures in which the break does not occur at 90 degrees. There are a few others, like I said. Those include epiphyseal breaks, Coles breaks, pot breaks, and several others. But these are the ones I'm going to hold you for accountable in lecture. All right, and when a bone is broken, it inevitably needs to be repaired, and that occurs in this kind of process. So when a bone breaks, you have the first step is going to be a hematoma formation, and that's when blood vessels in the bone tear and a hemorrhage occurs. And then over a period of several hours, a large blood clot or a hematoma develops. After that, the fibrocartilage callus formation. Capillaries are going to grow into the hematoma, and phagocytotic cells will then invade the area. Fibroblasts and osteoblasts will then migrate to the fracture. Fibroblasts will secrete collagen fibers and or differentiate into chondroblast that will secrete a cartilage matrix. Osteoblasts will then form spongy bone, and the massive repair tissue is going to be referred to as a fibrous callus or fibrocartilage callus. And then an internal callus connects the bone ends, and an external callus protrudes from the outer bone surface. From there, you'll have bony callus formation. And in bony callus formation, osteoblasts and osteoclasts will continue to migrate inward and multiply rapidly in the fibrocartilaginous callus. And then as this material calcifies, the tissue becomes a new bony callus. So there are a few things that can affect your bone health. One of those is exercise, and a lack of exercise and stress on a bone can lead to a loss of bone mass. This is known as osteoporosis, and we'll talk more about this as we get to some of the bone conditions later on in this unit. Another can be nutrition. Two aspects of that are calcium and vitamin D. And since the body cannot make calcium, it must be obtained from the diet. However, calcium cannot be absorbed from the small intestine without vitamin D, and therefore the intake of vitamin D is also critical to bone health. Dairy as well as leafy vegetables are a source of that calcium. And vitamin K also helps to support bone mineralization and may have a synergistic role with vitamin D in the regulation of bone growth. Green leafy vegetables are also a good source of vitamin K. So eat your vegetables, kids. Moving on, hormones. Growth hormones are synthesized in the pituitary, and that controls bone growth in a multitude of ways. It triggers chondrocyte proliferation in the epiphyseal plates that results in the increasing length of long bones. Growth hormone also increases calcium retention, which enhances the mineralization and stimulates osteoblastic activity, which then improves bone density. A few others. You have thyroxine, which is secreted by the thyroid gland and promotes osteoblastic activity and the synthesis of bone matrix. You have your sex hormones, your estrogen and your testosterone, that promote osteoblastic activity and the production of bone matrix, and in addition are responsible for the growth spurt that often occurs during adolescence. They also promote the conversion of the epithelial plate to the epithelial line, for example, the cartilage to its bony remnant, thus bringing an end to the longitudinal growth to bones and stopping that growth. Then you have calcitriol, which is the active form of vitamin D, is also produced by the kidneys and stimulates the absorption of calcium and phosphate from the digestive tract. We always hear a lot about calcium, and this is a big part of bone. So we're going to talk about calcium homeostasis here and the interactions of the skeletal system and other organ systems. The bone is constantly undergoing deposition and reabsorption in a process known as remodeling. Coordinating activity by osteoblasts and osteoclasts regulates both of those processes. There's going to be a lot of material in this, so just bear with me here. So bone deposition occurs where bone is injured or added bone strength is needed and is accomplished by osteoblasts. Okay. Bone reabsorption is accomplished by osteoclasts, and osteoclasts secrete lysosomal enzymes that digest the organic matrix and then secrete metabolic acids that convert calcium salts into a soluble form. There are several factors that are going to affect this bone remodeling. One is the availability of these nutrients, whether it be calcium or vitamin A, vitamin C, vitamin D, and then all the hormones that we just talked about. So this remodeling occurs under negative feedback hormonal control, and changes in the level of blood calcium will trigger the release of either parathyroid hormone, PTH, or calcitonin. And when blood calcium levels are too low, the parathyroid gland will secrete parathyroid hormone, or PTH. And PTH has three effects that all lead to a drop in blood calcium levels. It has a bone response, which stimulates osteoclasts so that they accelerate the erosion of bone matrix and leads to release of stored calcium ions in the blood. It has an intestinal response, where PTH enhances the calcium absorbent effects of the calcitriol in the intestines, and as a result, the rate of intestinal calcium absorption increases. And then it also has a kidney response, where PTH increases the production of the hormone calcitriol, which is continuously secreted by the kidneys at low levels. And this hormone, in turn, stimulates the calcium reabsorption by the kidney tubules. In contrast, when blood calcium levels are too high, the C cells of the thyroid gland will secrete calcitonin. And calcitonin has three effects, all leading to a drop in the blood calcium levels, similar to what we see from the parathyroid gland. It starts with bone reabsorption. Calcitonin inhibits the osteoclast, but does not affect the osteoblasts, so that they continue to deposit calcium ions into the matrix of the bone. It has an intestinal response. Calcitonin decreases the rate of the calcium absorption from the foods in the digestive tract, and then also has a renal response, where calcitonin inhibits the absorption of calcium in the urine, so that more calcium is excreted from the body. And then by providing a calcium reserve, the skeleton plays a primary role in the homeostatic maintenance of normal calcium ion concentrations of body fluids. The skeleton is also important in the homeostatic balance of other ions as well. Here you can see a diagram of some of the calcitonin function and parathyroid function. This is important to note that remodeling changes as your life goes on. One of the major dips you see here, and also major differences, is, if you follow the cursor here, is the difference in male and female. Where you start to hit 40 and between 50 and 60 years here, you see a stark drop in bone remodeling from females, and that's due to a loss of bone through menopause. Menopause plays a larger role in the production of estrogen in the female body. And if you go back to where we were a couple slides ago, we said that sex hormones, or estrogen and testosterone, play a major role in both bone remodeling and bone deposition. So the loss of that extra estrogen production in the female body during menopause can lead to osteoporosis. All right, there are several bone disorders that we'll talk about as well. You can have pituitary growth failure, or dwarfism, and as a result from an inadequate production of growth hormone, which then leads to reduced epiphyseal cartilage activity and abnormal short bones. This is rare in the United States because children can be treated with synthetic growth hormones. You have achondroplasia, which results from an abnormal hyaline cartilage development, and because hyaline cartilage forms the model for long bone formation, the individual will have short, stocky limbs, but the torso and the head are usually normal size. You can have Marfan syndrome, in which individuals are very tall with long, slender limbs due to an excessive cartilage formation at the epiphyseal plates. Other defects in the structure of connective tissues commonly cause life-threatening and cardiovascular problems. You can have gigantism, which is the result of overproduction of growth hormones before puberty. Puberty is often late at this point, and the most common cause is the pituitary tumor, which may be treated by surgery, radiation, or drugs that suppress the release of that growth hormone. You can have acromegaly, which results from too much growth hormone after the epiphyseal plates close, so that bones do not grow longer, but instead get thicker. And this is especially in bones that of the face, the hands, and the jaw. And this leads to changes in their physical appearance. You can have fibrodysplasia ossificans progressiva, which is a rare gene mutation that causes the deposition of bone around the skeletal muscles and normal soft tissues of the body. And there's no effective treatment for this painful and debilitating condition, and patients seldom survive into their 40s. You can also have Paget's disease, which is an overactive osteoclast that cause pores and weakenings of the long bones and lead to bending and bowing. Osteoclasts try to compensate for the overactive osteoclast, but the bone laid down is weak and brittle and prone to fractures. And on this page, I included a lot of different pictures of what you can see here.